Ladies and gentlemen, we are about to begin shortly. Please be seated and ensure your mobile phone switch off in the silent mode. For attendance, please kindly scan the QR code displayed on the screen. QR code is also available on both sides of the auditorium walls. Assalamualaikum warahmatullahi wabarakatuh and very good morning to our honorable guests. especially Dr. Examine Idris, our hospital directors, head of departments, specialists, MOs, nurses, and the rest of this respected HRPZ staffs. Thank you for allocating your time for attending our CFM session. I'm Elisa from ORL department, will be your MC today. Without further ado, I would like to invite Dr. Abdul Kafi bin Muhammad Ibrahim to present our today's CME with the topics of Ketum Chronicles When Your Brain Throws a Seizure Party. Please welcome.
Testing. Okay. Assalamualaikum, very good morning to the MC, Dr. Noor Elisa, our esteemed hospital director, Dr. Izami bin Idris, my respected HOD, Dr. Wan Rashdan bin Wan Abdullah, and to all of these ladies and gentlemen, esteemed colleagues. Thank you for joining me today. I'm Dr. Abdul Kafi bin Muhammad Ibrahim from ED. Today we'll be diving into a fascinating and critical topic, the impact of ketum use and its link to seizure. We'll explore the compiling case study, examine the pharmacology and legal status of ketum, and discuss emergency management strategies for status epilepticus. So to give everyone a clear roadmap, what we'll be covering today. Here's the outline of my presentation. We start with the case study, the Ketum Chronicle, and we look at what is Ketum, especially in Malaysia. Ketum doses low versus high effect to the patient. I'll touch a bit on emergency management of status epilepticus, and we'll be looking at the case series, seizure among young adults consuming Ketum beverages in Malaysia. And after that, we touch on the support for patient and what are the implications of Thailand legalization of ketum and cannabis to Malaysia. At the end of the session, we'll be having a Q&A session. So let's begin our journey by imagining ourselves in the chaotic environment of the emergency department, where every second count and every decision is crucial. So I want you to imagine yourself working in the red zone of the emergency department during a chaotic evening shift. Suddenly you hear a sound of 4-bell ringing, signaling a new case arriving in the red zone. The triage officer rushed in, pushing a 30-year-old male patient on a stretcher, urgently stating, "This patient is having a seizure." Immediate initial management is carried out, 15-liter high flow mask administered, and fortunately, the seizure is successfully aborted. As you struggle to get the IV line, you finally manage to secure one. Vital signs are taken, revealing the patient is hypertensive, tachycardia, and with a low rate of temperature, 37.7. Hypoglycemia is ruled out, but then suddenly the patient starts seizing again. As the patient is admitted IV diazepam, followed by IV phenytoin, the seizure activity temporarily subsides. You take this caution moment to gather more information from the family members. They reveal that the patient has experienced several seizures this year alone, with at least one episode each year for the past 3 years. Shockingly, the patient had never sought any medical attention for this event, further probing uncover a significant detail. The patient is a chronic ketum abuser, having used ketum consistently for the past 5 years. So, now that we explore a specific case, let's dive into a broader concept of ketum in Malaysia. I'm sure everyone is very familiar with ketum, but let's see what ketum really is and what are ketum implication in Malaysia. Ketum or kratom in English, or in the scientific name Metragina sapijosa, is basically a tropical tree native to Southeast Asia. It's also known as biak, kutum, pokok biak. Basically, it contains mitragina and 7-hydroxymitraginin, which produce this stimulant and sedative effect to the patient. So, historical context, basically used in rural Malaysia for centuries. It is often chewed, smoked, or brewed to treat pain, diarrhea, and boost energy. In modern usage of ketum, it is still popular in rural area, but it is increasing misuse, especially among younger population seeking its psychoactive effect. So, moving on, let's talk about traditional drink that has gained notoriety in northern Malaysia, Cakoroy. So basically, it's a term in northern Peninsula Malaysia, especially in Perlis and Kedah. It actually refers to a mixture of ketum leaf and cough syrup, and often mixed with a carbonated drink for the psychoactive effect, including euphoria and increased energy. So let's touch a bit on the legal status of ketum. Is it actually regulated under the Poison Act and amended in 2022, which make it illegal to possess, sell, or consume ketum in Malaysia. And any violation, patient can be fined up to 10,000 ringgit and imprisonment up to 4 years or both. So the challenges in rural poverty, basically the cultural acceptance pose challenge to the law enforcement, and the thriving black market for ketum with smuggling and illegal cultivating reports. So I got a statistic data which is quite old, is 2013-2017, showing that the ketum abuser at that time is more than 120,000. Indeed, you can see in this picture. So what are the health implications of ketum? Mostly independence and withdrawal. When patient become physical dependent, the withdrawal symptom may include irritability, patient become anxiety, mouth ache, and insomnia. And the adverse effect usually GI issue, liver toxicity, seizures, especially with prolonged or high dose use. For public health concern, it is actually associated with health risks, and healthcare providers need to be aware to provide appropriate care and counseling to the patient. So let's touch a bit on the ketum dosage, low versus high effect and risk. At low dose effect, usually around 1 to 5 gram, it will cause stimulant effect to patient. Patient become energetic, more alert, and sociability. And it also enhance the mood of patient, because patient improve the mood and sense of well-being, and it also have mild analgesic effect. However, at high dose, which is around 5 to 15 gram, it has a sedative effect, which causes the patient to become more relaxed, drowsy, and sense of calm. And it has a stronger analgesic effect, and patient will become euphoria. This is where the adverse effect come in. Patient become nausea, vomiting, constipated, and also seizure. So what we can conclude from ketum dosage, we can say that a low dose, it actually behave like a stimulant, more like a sympathomimetic drug, and a high dose, it actually behave like an opioid. So let's touch a bit of our emergency management of status epilepticus. So the initial management, which is an stabilization of patient, should be done within 5 minutes of patient arriving at ED. First thing first, our ABC, ensure the airway is open and clear, administer oxygen adequately, secure the IV line, and also your vital sign, including BP, heart rate, respiratory rate, oxygen saturation, and temperature. And then our first line of treatment of status epilepticus. First line is always benzo. This is what I got from the up-to-date. They are using lorazepam, but in our country, local, we are using diazepam 0.15 mg per kg up to 10 mg per dose for adult, or midazolam 0.2 mg per kg up to 10 mg per dose. So moving on to our second line of treatment, which should be given to patient within 10 to 20 minutes of patient arriving in ED, which is our anti-epileptic drug. Our first line of choice should be phenytoin, 20 mg per kg, not exceeding 50 mg per minute. And also we can consider Keppra, levetiracetam, 40 to 60 mg per kg with maximum of 4.5 mg, 4,500 mg, 4.5 gram, or valproate acid, 20 to 40 mg per kg with maximum of 3 gram. If the patient is contraindicated to phenytoin, or it is not available. The investigation or monitoring should be done earlier. So from the blood test, we should rule out any cause of seizure such as hypoglycemia, the glucose, any electrolyte imbalance, hyponatremia, any calcium, magnesium renal function should be taken, liver sensitivity and toxicology screening appropriately. Patient should be sent for imaging, for a CT scan or MRI for certain cases, and lumbar puncture later if suspected any infection, and EEG monitoring if the seizure persists. We should bear in mind there's a lot of differential diagnoses when patient come with seizure, especially with prolonged seizure. One of it, the common one that we find it should be metabolic causes, hypoglycemia, hyponatremia, or hypercalcemia or hypomagnesemia. Any infections such as meningoencephalitis, any toxin or intoxication, especially alcohol withdrawal or any drug overdose, and any structural brain pathology such as tumor, stroke, or in trauma case should be TBI. Patients should be put on continuous monitoring and support, cardiovascular and respiratory monitoring continuously, and then patients should be reassessed frequently to adjust the treatment. And also, patients should be prepared for intubation in case of patient having respiratory failure or any prolonged seizure. So this is a diagram that I took from UpToDate. Actually, same as what I already explained, but in diagram to make you guys understand more. So we start with the pre-hospital setting or ED setting, management of patients, stabilize and support the airway breathing circulation of patient with adequate oxygenation, and then adequate monitoring, cardiorespiratory monitoring, including the SpO2, secure the IV line, and also draw the blood to identify any differential diagnosis that cause the seizure. So simultaneously, patients should be given benzo depending on whether we got the IV line or not. If we get the IV line, we should give the first line of benzo, diazepam, and also our anti-seizure medication, phenytoin. And then if seizures still continue, we can actually give another second dose of benzo. And if the seizures still continue after that, patient should be consulted to neurologist for EEG. And if seizures still continue, we can actually add another 5 to 10 mg of phenytoin, make it 30 mg per kg, which we already given 20 mg per kg initially. Or we can use another 2 anti-epileptic drugs that we have not given earlier to patient, and also patients should be transferred to ICU. If seizures still continue beyond 30 minutes, if patient was not intubated earlier, patient should be intubated, and we should start infusion of propofol and midazolam. For post-seizure care, patient should be put on continuous monitoring, which is including the neurological status and vital sign. Once stabilized, we should gather the detailed history to identify the potential trigger and contributing factor, and also patient disposition. Patient to be referred to appropriate team for further workup and management. And also for the long-term plan, patient should be given anti-epileptic therapy and also proper follow-up care. There are actually 2 lab testing specific for ketum, but it is not routinely done, especially in ED, which is one is the blood testing, which is we test the alkaloid, particularly the metraginin, and also urine test. This is quite, actually urine test is quite fast. The result is quite fast, but we are not routinely do the testing for ketum. So let's touch a bit about the case series conducted by a neurologist from USM, Prof. Saneha and team. Essentially, they study seizure among young adults consuming kratom beverages in Malaysia. Is a case series. So the objective of the study, they want to investigate seizure among young adults who regularly consume ketum beverages in Malaysia. There's 5 young adult participants, aged around 20 to 29 years old. So what are the findings of the study? First, the seizure characteristic. Majority come with GTC, and usually it occurs within hours to days, and some may experience recurrent seizure over weeks. So for patient profile, patient has a regular ketum abuse for several months and can be up to years, and there is no other concomitant drug reported. So patients usually come with hypertension, tachycardia, with a normal blood glucose, and the initial neurology exam usually there is no focal deficit. So management and treatment that they propose, same as I already explained earlier. First line benzo, and then anti-epileptic medication and close monitoring. And what are the outcomes? Actually, all the patients recover without lasting neurological deficit, and they highlighted a need for public health education for Ketum. So what are the implications of the study? For us, we should be vigilant about the potential Ketum-induced seizure, like in this case, especially in young adult with a history of Ketum use. For public health, they should need to increase the education awareness campaign and the regulation, which have been done by the government after 1 year release of this study, which is this study is released in 2021. So in 2022, as I explained earlier, they already amend the Poison Act for Ketum. So what are support of patient overcoming Ketum addiction? We can offer rehab or counseling to the patient. Rehab, it can be inpatient or patient program for the patient, and or integrated treatment plan, which we combine medical treatment with behavioral therapy to address both physical dependent and psychological aspect. And we can apply counseling and support group to patient. Patient can go to individual counseling, one-on-one session, or group therapy for them to support each other. For preventative measure, for public health campaign, they should raise awareness about the risk of Ketum and promote healthy lifestyle. We can do a program at the school to educate the younger generation about substance abuse, including Ketum, and community outreach to actually engage with patients with struggling with addiction. So as we all know, Thailand already legalized Ketum and cannabis. Let's look at what are the implications to our country. So in 2021, Thailand already legalized Ketum for medicinal purposes, and also cannabis already decriminalized in 2022 for medical and industrial use. So the impact to our country, of course, it will increase smuggling risk. So as you heighten the border, public health concern, especially for Malaysian who travel to Thailand, and potential health issue. We increase Ketum and cannabis related health issue in Malaysia. So I think that's all from me. These are my reference. Any question from the floor? If no question, I will ask. Sorry? Findings.
Saya bukan nak komen tentang itu. Saya nak komen tentang how you prepare your slide. Bila kita prepare slide ni, kita nak kongsi dengan audience. So that's when we talk, the audience can also read, can understand better, can grasp the idea better lah. But your slide ni is not visually friendly, dia tak nampak. Kecil sangat.
Oh.
Kalau pergi dalam komputer tu terang kan. Tapi kita dekat saya sendiri pun tak berapa nampak. Kalau clinical observation pun the color contrast is not striking.
Sorry, saya tak perasan kat sini. Saya tak perasan kat sini.
So next time when you prepare your slide, you must make sure your slide is readable by the audience. Then the impact will be greater, right? Pada keseluruhan adalah saya observe, right? Your slide is like this, right? This is your biggest slide. Ada lagi banyak slide yang memang aku ni nak baca, tadi nak follow what I already said. Itulah my comment.
Thank you.
Kalau nak tanya tentang ketua ni, saya nak tanya how big is the problem in your capacity for operation and with custom complication di Kelantan?
It's not that common lah, yang ketum come with seizure, but actually we do get one or two cases macam 2 bulan sekali macam tu lah. When I was in USM, I think more common kot. That's why they can conduct the study lah, Masaneha, penting. But mostly you come with dia tak akan datang dengan status lah actually. Dia tak akan datang up to intubation lah, status up to anti-epileptic drug and then subside lah the seizure tu.
So yeah, this patient consume ketum and the seizure. How do you really sure the ketum can cause seizure rather than patient may have underlying epilepsy?
Yeah,
That is it may occur before the consume ketum, long time ago or maybe after patient consume ketum. Maybe the exam ada proof epilepsy or the itu tidak sure. Then patient ada epilepsy and sometimes the consume ketum ada seizure. How do you really sure that the causes ketum rather than epilepsy?
For this case, actually the patient has no medical illness. Previously, patient ni never see any medical attention. So for our differential diagnosis, and patient is a regular ketum use, as you can see finding from the study as well. It actually sama lah lebih kurang dengan this patient punya history. But to be sure that patient ambil ketum, so the blood test lah, the blood test tu, and one of the differential should be ketum-induced seizure. And also, as I explained initially, based on the differential diagnosis, we have to rule out other causes of ketum-induced, other causes of status epilepticus for this patient lah. One of which should be ketum-induced, especially in the prolonged use of ketum and recurrent seizure. But as you mentioned earlier, memang have to rule out other causes lah. Patient kena buat EEG as well lah.
Okay. Apa yang Dr. Razin mention lah. In fact, you can easily upload your punya slide to AI untuk improve your punya slide. Sekarang lah.
This is I did with PowerPoint dia yang suggest macam ni.
Kita try gamma ke ataupun lain-lain lah.
Alright.
Then second question, mention ada yang low dose dengan high dose kan? So actually berapa keping daun ketum akan produce yang high dose? Okay.
I'm not sure about that.
Traditional use yang saya tahu lah, dia kena guna dalam 2-3 keping daun ketum dia untuk satu produce. Bila check dalam literature, actually satu keping daun ketum yang 1 gram to produce about 1 gram of satu keping daun ketum about 1 gram of metaginin. So kalau dia kata low dose is 1 to 5 gram, maknanya betul lah dia punya betul. Dalam 2-3 keping dan you dapat dalam 3 gram untuk low dose. More than that, you will get high dose punya betul-betul lah. In fact, kalau pergi dekat rural area, sekarang dia satu periuk tu sampai 20-30 keping.
Like this picture, dia boleh tak banyak ni.
Just a comment.
Thank you.
Ia sebenarnya yang panggil dan yang ada dalam itu hijau dan merah. Dan kerana itu sebenarnya reflect dia punya kandungan macam Zainab sebenarnya yang paling rendah adalah putih. Walaupun hijau dan merah dia bukan sebenarnya. Biasanya yang putih dan untuk sedikit effect sebenarnya. Yang lain tu yang ada yang hijau putih yang okey dan biasanya kalau benda less dan sekali rebus tu kurang daripada 10 helai dia biasanya dah untuk pokok pakcik-pakcik ke sawah and all that. Maknanya it's not addictive. Yang heavy use ni, benda yang addicted ni, dia orang akan rebus tu at least setengah kilo ke sekilo sekali rebus. Kalau by plastik dia jual ikut sumpit more than 5 sumpit, 5, 8 sumpit, 10 sumpit sekali minum sehari itu adalah heavy use yang kita kira addicted. Dan untuk yang dapat seizure, usually dia memang minum banyak dah sebenarnya sekali rebus 1 kilo. Kalau just setakat sikit-sikit tu dia cause seizure actually. Itu adalah untuk keratung. Dan kalau yang memang heavy use tu sebenarnya dia orang memang kena minum 2 jam sekali tau sebenarnya. Sebab the effect is very short. Jadi dia minum 2 jam sekali. So kebanyakan yang heavy use ni memang tak puasa lah sebenarnya. And we can use that argument for them to stop lah kalau yang memang dah sampai wahyu. Sampai seruan nak berpuasa, sampai hidayat tu kita boleh cakap macam tu lah. You have to stop this sebab you memang tak fasting pun sebenarnya. Dia memang kena guna 2 jam sekali. That's how bad keratum is. And for the psychiatric part actually, now we are seeing increasing number of patient admitted due to anxiety symptom or psychotic symptom because of keratum use. Before this memang tak nampak sangat actually. Saya rasa dalam 2-3 tahun kebelakangan ni semakin ramai patient yang admitted. Tapi usually yang ni satu heavy use, satu lagi adalah yang dia one mix. Dia bukan yang pure rebus sendiri tu tak. Sebab even yang kita rebus sikit tu pun memang pahit dah. Jadi usually yang banyak ni they mix with coffee, whatever tu kan. So usually yang tu memang hardcore lah. Yang tu yang biasanya datang kat kita sama ada fit ataupun they come with all the psychotic or manic symptom.
Thank you. Thank you. Saya baru tahu ada 3. Selalu dengar daun merah apa? Urat merah kan.
Dan sebenarnya ketum Malaysia kualiti paling baik dekat US kan dia orang jual dalam kapsul lah ataupun tablet tu kan, dia orang akan market benda tu sebagai keratum dari Malaysia. Jadi walaupun dia ambil daripada Indonesia ke daripada Thai, tak pasal-pasal kita dapat nama kan. Sebab apa ketum Malaysia ni kualiti tinggi? Sebab kita petik, bukan jatuh. Kalau kat Thailand dulu sebab dulu dia tak legal kan, jadi dia jatuh bawah dalam hutan kan, ketum kan pokok hutan. Jadi ada najis binatang, sebenarnya issue of that. Sebab ketum Malaysia ni paling tinggi kualiti. Dia kira macam tu.
Thank you for all the questions. So I prepared the question for the audience. Okay, sorry. Saya terbagi jawapan. So, what are other names for ketum?
Yeah.
Okay, betul. So, dia ada banyak nama lah, especially dalam negara kita yang banyak negeri ni. So, ada panggil biak, ada panggil kutum, ada pokok biak. So, second question. How do low versus high dose of ketum behave? Orang yang sama, tapi tak boleh dapat hadiah 2. Tak ada jawab, saya ambil hadiah. Tak ada. Senang je soalan ni.
Euforia.
Okay, boleh lah jawapan tu. Atau kita boleh cakap low dose tu dia macam symptomatic drug lah. Atau kalau high dose tu macam opioid drug. So third question, what are the first line and second line treatment of status epilepticus? Yeah. Alright, first line should be your benzo lah. Always benzo. Second line, anti-epileptic drug. Ada tiga choice. First choice should be phenytoin lah. Alright. With that, I finish my presentation. Thank you. Nadia. Extra question. Question. Siapa ingat find that possession or consume of ketum in Malaysia?
Peraturan racun 1989 bahasa psikotropik denda 10,000 tahun 5 tahun penjara.
Betul, denda 10,000 ataupun 4 tahun penjara atau kedua-duanya sekali ya. Okay, right. Thank you. Okay, thank you.
Right, thank you very much to Dr. Kapi for the great and informative presentations. We now so any questions from the floor before we end our ceremony? Anyone? No question from the floor, right? All right, so I would like to invite Dr. Izamin bin Idris, our head director, to deliver the certificates of appreciation to our respected today's CME presenter. Please welcome Dr. Izamin and Dr. Kapi to the stage.
Sure. Yeah.
Thank you very much. So with that, we have to come to the ends of our today's CME topic. The upcoming CME will be presented by Dr. Nurul Shahada Hasmi from ORL department with the topics of tracheostomy, which is trials and tribulations. With that, thank you everyone, and thank you for attending our CME today. Have a good day, everyone. Thank you.